Hey, everybody. Welcome back to the Overrun on YouTube. Ed Bowder and Dan Schwester here with Josh Kimbrell, who is a paramedic up in New York, and Judah Kreinbrook, who is a medical student at Duke University. Hey, guys. Thanks for joining us.
Hey, thanks for having us.
So a couple of weeks ago on Journal Club, we talked about this paper that you wrote. This is false electrical capture in pre-hospital transcutaneous pacemaking by paramedics. This was a case study. So I'm going to bring this up on the screen for a quick second, and then you guys can talk about this study. But essentially what we talked about was we were looking at, the study is published, how effective are we at pacing? And it turns out not so great. So I want to hear what you guys think about this. What was the impetus behind researching this, and what have we figured out from this? We'll start with you, Josh.
Yeah, so this kind of impetus started based on a case I had back in, I think, late 2022. So in my primary role, I work as the quality manager for an EMS network in New York City, Medicine's Health Network, Jamaica Hospital and Flushing Hospital. And we had a case where I saw false electrical capture, and I reached out to our medical director. And I was like, hey, Dr. Giglio, I have this case where our crew thought that they had captured, but they didn't. They said they felt a pulse. The patient ended up going back into cardiac arrest. Here's this issue. And he's like, I've actually never heard of this. I've been working EM for a while. This isn't a concept that I'd heard of, this kind of false electrical capture. And so Tom Boothele, who has been very involved in the kind of EMS educator and like clinical quality evidence-based medicine space in EMS since like the 2000s, late 2000s, he'd done a series of blogs on his EMS 12 lead page where he talked about this kind of artifact you can get from pacing that can look like a QRS if you're not super adept at recognizing this thing. And so I ended up reaching out to him, and I was like, hey, Tom, I know you don't know me, but this issue is really common in our system. And I went on PubMed, and I found that there's basically no research on false electrical capture at all as a concept. And so I know you're an expert on this. You've been talking about this for a while. I want to do this in our study. I want to have you join and help make it better. And I want to introduce this to the literature because I don't think a lot of people know about it. So we did it as a case series like this, even though you might have called this a retrospective cohort or a few other things. But we did that because we wanted to be able to flesh out a few of the cases so that you could look at the ECGs, you could see what it looked like down in the discussion. So that's kind of how we got started. I reached out to Judah a little bit after we started this project, and this is something he was really fired up about as a paramedic in medical school and kind of advancing the craft. And the state of the science for transcutaneous pacing was pretty weak, which is something that Judah is really passionate about, like pushing forward. So that's kind of the start behind this story.
And Judah, when we hear that the data behind this is weak, and certainly we had a couple conversations off the air about our passion for improving this education.
Yeah.
From your perspective, when Josh reached out to you and you saw this idea, I want you to tell me what you thought about that, and then let's get into some of the meat of the paper.
Yeah. So initially I thought, okay, well, this seems reasonable. You know, the way I always try to evaluate something research-wise is like, one, do I think like my involvement in this is going to potentially impact the science? Two, do I think it's feasible given my time, line and busy medical school schedule? And then also, do I think that it could potentially, if our hypothesis is correct, change, the actual clinical care down the line, right? And for me, it was a yes on all three of those questions. I think that a big factor here was that I've followed Tom Boothele's work for a while. I had seen the cases that he had written about. I, had been familiar with some of Josh's work. I think we had, touched base on Med Twitter of all places, like a couple months prior, because he had like some mutual follows or whatever. And we had quickly like struck up a friendship just talking about evidence-based medicine and EMS. I'm interested in potential critical care cardiology. I'd been a paramedic for forever. And so I love pre-hospital cards research, anything to do with pre-hospital cards. And I thought that the idea had merit, right? If you look at the evidence base for TCP from the AHA perspective, it still has a class 2B recommendation since 2006. There's a reason for that. I don't want to bore anybody with the details of that right now till we dig into this paper. But I love like Josh said, I love talking about, in my opinion, the shitty research that TCP was based on to begin with.
And Dan, you and I have spent plenty of time talking about the glacial pace of research in EMS. So I know what my thoughts were when I saw this paper, but I want to know what you thought about it before we brought these guys on.
I thought it was a really interesting topic. It's definitely, I mean, I think that there is not enough EMS research. I think a lot of what we do is voodoo. You know, it's like there's no basis for it, but we do it. And we have no evidence because we don't study anything. And, you know, if you've been on the show or you listen to us, I ran about this pretty much almost every time, is that, you know, we talk about evidence, but it doesn't exist. We don't have anything. We have a couple things here and there, and, you know, we've got to do this stuff. We've got to figure out what works, and we've got to have unbiased stuff that's not made by a manufacturer or somebody who's got a vested interest in the company or the medication, and, you know, that can tell us, is what we're doing making sense? Does it work? If it doesn't, what do we need to do to make things better?
No, and I think that's absolutely right. And for what it's worth, this paper came out was received in 23. This came out in February of this year. So this is it's still new. The reason we're talking about it now is that it's not going to get out into your textbooks in a while. So if you're currently in medic school and you want to know how well we're doing with pacing, listen to the Overrun. Follow Josh Kimbrell and Judah Kreinbrook on social media, and you'll know where we're at. So let's get into how this paper works for some of them. Judah, you mentioned that the 2B recommendation for the AHA. For those uninitiated, clarify what 2B means.
Yeah, so 2B really means that there's no good evidence to go benefit over harm. However, there's not only no evidence, but there's just the kind of like the expert opinion or thought that it could be slightly more beneficial than harmful. So we're going to give it a nod of approval, but not a full nod of approval. So if you were class 3, you would be a intervention that has definitive evidence of harm. And if you were class 1, you would be an intervention that has usually randomized evidence showing clear benefit. And the reason that this is 2B is because if you look all the way back, the original trials of transcutaneous pacing were actually done in cardiac arrest, not in bradycardia. They were actually subgroup analyses for the bradycardia patients, and you cannot issue a class 1 recommendation based on a subgroup analysis. And so they've gotten this kind of 2B recommendation.
And just so we're clear, that means that in the setting of bradycardia, using transcutaneous pacing is a little bit more effective than using a hammer. That's where we're at. So that just so we're absolutely clear with what this clarification is. So again, we looked at the group. I don't know if there's any real surprise that the age was in the 70s. I think that's typically when we would see people. But what I'm interested in here, and I guess before we get into the strips, both of you, Josh and Judah, do you feel that these errors were more provider-specific errors, as in like the provider was working with the patient and missed something? Or do you think that this is more of a function of perhaps improper training or improper education about pacing? Where did you guys find, I guess, the causative factors for these things?
Yeah, Josh, I'd love for you to follow this up, but I'll just give like a short kind of dichotomy with interpreting this paper that I think is important. It's important that you understand there's a difference between failure to capture and false electrical capture. Failure to capture is when you use the device, you identify it's not working, and you switch gears. You say, no, this isn't working. I don't have capture. There's not a clear QRS. I don't have mechanical capture, whatever. The way we defined false electrical capture was that you did not have electrical capture with the caveat of the provider wasn't noting that they recognized it, or the provider wasn't, even if they were trying to fix the problem, they were still documenting that there was a palpable pulse. If you look at, our abstract and littered throughout the paper, all 23 of these patients supposedly had documented mechanical capture. And so while we can then kind of hypothesize, because after all, most observational research is hypothesis generating, while we can hypothesize what the causative factors of that are, I think what observational research can show you is it can describe a problem. And so I think here we've described an issue, not with failure to capture. Yeah, it could be. Maybe there's no way these patients could have gotten capture to begin with. But rather, this is a problem with people recognizing when that's occurred.
Right. It's more of an erroneous capture than false capture, right?
Yeah.
Yeah.
We think
Josh,
it's
what do you think about
working, but it doesn't work.
Yeah. What do you got, Josh?
Yeah. So I guess to get to like the root of your question, which is like, is this a systemic issue or were like certain clinicians screwing this up? I can tell you in our study specifically, and I think in EMS generally, the system was designed to get the results that it got, right? So we're sitting here, we trained paramedics a certain way, or didn't train them really at all. We have a protocol in New York City that says begin transcutaneous pacing, and that is the sentence. There is no, you need to use a pleth wave to confirm with each QRS. There is no, you should expect to be at least 80 milliamps as a threshold for your current. There is no, we prefer anterior posterior pad placing. There is no, please use the femoral pulse site instead of the radial pulse site or the carotid pulse site. I think there are so many systemic factors that make this difficult. This is perhaps an error on the clinician, and I'm like willing to admit that, but we set them up for this failure systemically. So I think these calls are always incredibly difficult. I think maybe around half, a little bit more of these cases were post-cardiac arrest, which from a human factors perspective is a lot to manage, right? Many of these people had norepinephrine infusions, they were intubated, and they had all of these different things going on. And even for the patients that didn't, you're managing a lot in your scene. And so when we have this procedure that hasn't been taught really clearly based on evidence, because really there isn't any, of how to do this properly, we're setting people up for failure. And I mean, we found here that only 4 of the 23 cases had true electrical capture for the duration of pacing, which is pretty low. And I think unless you have 5 people who are doing all the pacing and they're doing it wrong, which is not the case, then it's a systemic thing and not an individual clinician thing.
We had our top 5 providers work on this study, and that was it. Yep. So I'm gonna go through these strips that are on here because I think this is what really actually sort of shows. Also, I really love these violin plots that show false capture and true capture. This shows this as a reference to systolic blood pressure. So if you're ever not really sure if you have effective mechanical capture on the patient, take their blood pressure. If their blood pressure is still low, you don't have capture. But failing that, I want to look at these strips here because I think this is one of the most important parts of the paper is you guys didn't just discuss what you saw, you gave very specific examples. And Danny, looking at this strip, I think a lot of field providers would look at the beginning of the strip and see that there's a couple QRS complexes that are marked and assume, okay, now we're pacing just fine. And then kind of as you move down the strip, you can see that the electrical pace isn't actually hitting the QRS complex. So Dan, is this something that is just something that we easily missed? Is this apathy? And I did like Josh's thing of you get the system that you prepare, to have. And I think that's right. But if I'm just out in the field and I see this strip, give me steps to, I guess, work past this.
All right. I mean, first of all, I agree with everybody here. We don't teach this. We don't train it. We don't practice it nearly enough that we should. Transcutaneous pacing, it's a crapshoot, right? We're taking a lot of electricity, slamming it through somebody's chest in the hopes that something's going to work on the inside. We don't know what the impedance is. We don't know whether the pads are where the pads should be for best placement. We have no evidence for any of that. I think there's a lot of clinical tips here that there's a few that you can take out of this, right? First and foremost, that pacer spike has got to be with a QRS complex. If it's not in front of the QRS complex, you're not stimulating anything, right? If you got a pacer spike and then you have a after that, there's a problem here. Secondly, understanding and this is another failure of training is not everybody, and I think Josh hit this, is when we were talking earlier, not everybody's going to start showing capture at 60 milliamps or 70 milliamps. You're going to have to watch these people. You're going to have to turn that up. The third thing was a really good point that was made about a pleth wave. These people need to be on full monitoring. You need that pulse ox on there. That pulse ox should correspond to the capture that you're seeing on the ECG. You should see a increase in blood pressure. Again, if you're not seeing an increase in blood pressure, something's wrong. Remember, we're stimulating a heart to beat. if we're not getting any benefit out of it or output, then something's wrong. Also, I think end title is a good option here. If your place uses nasal end title, this is where you want to put it on. Again, improved perfusion, you're going to see that end title go up. You're going to see them. All of these things, right, are just more signs that you're probably on the right path. If you're just getting a radial pulse and saying, yeah, I think it's there, you're opening yourself up to this.
Right. Well, and the other thing that I think providers have to keep in mind is that if your heart rate is around 78 and you feel, your patient was at 20 and now you're pacing them and you feel their heart rate around 78, you have to take a second and realize like, oh, that might be my heart rate. And, there is some evidence that shows that AP placement is a higher capture rate than anterolateral, to the tune of around 88%. You're better off with capture to AP. But one thing that I always worry about is how, and I hate to use the words apathetic or lazy, are providers that they won't roll the patient over to do an AP placement. And there's other concerns there too, where if your patient is already in the back of the ambulance, a lot of providers, either out of apathy or habit or whatever, will just do an AA placement or anterolateral placement because that's what they're accustomed to doing. Because I think people tend to kind of fall back on their previous patterns. And something else that was really cool, with these strips.
I do anterior more than AP. And because you just get on, you see it, it's like, okay, slap the pads on,
Right. Yeah. And I think that's largely a function of, and again, this isn't a criticism, it's just how it happens. I think that's more of, habit, availability. I think in a lot of settings, we'll see a patient that needs to be paced and we're just like, oh, well, it's quicker to get, an AP placement or an AL placement than AP placement. Right. But again,
I think
go for it.
Now, another key here I wanted to make sure we talk about, Ed, is like if we zoom in on that first figure and we look at that black circle, we drew that specifically. And, any paramedic student or anybody that's listening in, I think really like getting good at understanding that this isn't just a problem of like, oh, well, it's, really easy to interpret and you're just making all these errors due to these systemic factors. Yes, there's systemic factors. You might have bad pad placement and all this, but if you look at that, that is what we call a phantom complex. So that's actually electricity distorting the natural, the natural underlying rhythm. And that isn't a QRS. That is the pacemaker's deflection that gets picked up and interpreted. But if you zoom in, if you go to Tom Boothley's work, that looks like a QRS minus an ST segment and clear T wave. But when you're going down the road or you're, rushing around post ROSC, that's really easy to confuse that with a QRS, right? So this is where those multiple modalities of confirmation come in.
Right. And that gets down to a continued reassessment, right? And really, it feels like all we're doing right now is we're just kind of parsing the things that we're told to do in the first place. But again, we're told to do certain things, and then I'm not convinced that that's actually how it happens in the field, right? I think a lot of times if you're pacing somebody, we usually throw the pads on, get capture, and then frankly, I think a lot of us just pray that we get to the hospital in time. But missing a phantom beat and missing that capture is something that can happen in a lot of cases. I do want to point out these sort of wide and aberrant complexes here. This is again for figure 4. Because a lot of times you can get someone who's paced, you start seeing these big wonky complexes. In fact, I specifically remember being taught that if you're pacing someone and you're not sure if you have capture, look for big wonky complexes. And again, this kind of shows that's not really the case. You might just have really, really ugly artifact. So Josh, help me out on that.
Yeah, no, I love that you said that because I specifically remember being trained in my, paramedic education, which had great instructors that certainly meant the best. But I was taught that you would set the current, you would start the current, you would roll it up until you saw this wide, bizarre looking QRS complex. And there was no description of looking for a T wave or being skeptical of getting that capture at a lower current. And so we shouldn't be surprised when paramedics throw the pacer on, which is something they do, maybe once a year, maybe twice a year if they're in a really busy system. And they crank up the current and they look at it.
And then one other time.
Exactly. And then they look at this electrical artifact and they see it's wide and it's big and they're like, oh, that must be it. And if you look at figure 3, which I know isn't the wide aberrant that you're talking about, but you can see there's a marching bradycardic rhythm through this. So when you're feeling for a pulse, you could even be feeling the patient's pulse at a rate of 20, and also the muscular contractions that probably have some pseudo-pulsatile flow that make the pulse palpation really, really difficult. And so I think really trying to slowly ramp up that current and looking for a change in morphology as opposed to like, you know, cranking the dial on the life path and like looking and seeing if it's there, looking for it to actually change and being very skeptical, right? I think with intubation, we've been trained like no waveform capnography, pull the tube. Like that's just 100% thing. I think here it's that same thing. If there's any doubt that you're not doing it right, you need to abandon it, because this could be a really big problem if you don't recognize maybe the patient go into cardiac arrest.
Yeah. And there's other, again, you have other notes here that I really like. There's one here, true capture, that was confirmed by pulse oximetry. So here's another thing. We have a big, you know, wide, ugly kind of aberrancies here. But, you know, this is showing your true electrical capture. True electrical capture on a strip should be ugly. That's just what it is. But you should also feel corresponding pulses. And the paper goes more into this. I am going to link this paper in the show notes, but I do want to take some time and just kind of, when you guys were going through this work, I want to know what opinions you had changed. So Judah, when you were working on the paper and you were going through, you know, different documents, different charts, did you have anything that was like, you know, I think medics are really, really good at pacing and you were wrong? Or what is it about this work that kind of changed your mind about pacing specifically?
Yeah. I mean, I think I was surprised to see the incidence of false capture being so high, right? You know, I expected there to be some sort of, you know, underlying rate of false electrical capture. I just don't think I expected it to be anywhere near north of 80%. I expected it to be far under 50, maybe
surely
20,
1 and 2
30%.
is fine.
Exactly.
Surely we're crossing 50%.
I was stunned by the numbers, to be honest with you. I thought, like you did, I was like, yeah, it happens, but once in a while, over 80%. Like, wow, just blew my mind.
And so I think the other thing that really surprised me is on the cardiology end of things. And, you know, I will put this out on the air because I do not care. I think the American Heart Association has done a terrible job of, you know, supporting pre-hospital cardiology research and pre-hospital cardiac emergency research. I think like the fact that if you look in their latest 2018 guidelines, they actually talk about false electrical capture. And by the way, anyone who has the ACLS expert provider manual, whatever expert wrote that, talk about false electrical capture, but not in such certain terms because there's no evidence to really use to talk about it. There's a couple papers from the 80s and
there wasn't up until a couple months ago.
Well, exactly. But I think there's not a lot of research on this, and the fact that you have an intervention that has such an obvious problem, no one's put 2 and 2 together. Josh and I are really concerned. If you look at case number 3, this patient was in unrecognized cardiac arrest until they transferred over to the hospital. So how often is unrecognized cardiac arrest really occurring in these patients? We just don't know. I think that I would much rather a medic, to be honest, go to, you know, if they feel like the intervention's not working, just go to dopamine or a push pressor and, you know, at least they can assess their patient going back into cardiac arrest or cardiac arrest for the first time, right? If you don't, I think what I was surprised at, honestly, is how dangerous this could be and how little data we have to inform overcoming it. We have no data on whether pleth is going to work. We think it might work. We have no data on whether end tidal actually increases. We think it might increase. The only data I could say we definitively have, and I would be willing to like work with anybody to actually make this a guideline and gold standard, is if you have POCUS and you can verify with somebody who has expertise in POCUS that you have a mechanical squeeze with each pace, you definitively have capture. I think that is the only thing that you can use. And I think pulse palpation, frankly, I would be okay if a medic never assessed a palpable pulse in this. I think you could get away with femoral. I think that you could correlate it, but it seems so unreliable to me. And the likelihood of pseudopulsatile flow, you know, I think it's garbage. The fact that all of these patients had documented mechanical capture with palpable pulses, I think it's kind of a nail in the coffin for me, at least, that something's up here and it needs to be looked into further.
And just to
No,
just
and
to
I think
add
that's
on,
right too. Yeah.
just to jump on with that, the idea about the AHA, they know that pulses are erroneously taken. They know this. This is why they've changed their guidelines. Have literature on this to support it in the cardiac arrest world, where we're told, listen, just continue doing compressions, even if you get an organized rhythm. We want you to do that for 2 minutes. And they say pulses are unreliable. If you don't have signs of life, go ahead and start compressions. It's astonishing that they would think that wouldn't happen for things like TCP, because you already just said it happens in other circumstances.
It does. I think what's probably preventing it, and this is something that happens when writing large guidelines, is I doubt that they actually have a lot of pre-hospital practitioners to help interpret this data, as well as there's no empirical data like ours to talk about how often does that occur. And so if their assumption is that this is like a rare occurrence, or that, providers in the pre-hospital setting will realize when false electrical capture is occurring and the pulses are unreliable, they never say that explicitly. So I think, this is partly on them for not saying it explicitly, but also it might just be the fact that we need more pre-hospital focused cardiology researchers. Absolutely. We need more folks from the pre-hospital sector if you're going to talk about a treatment that's primarily used pre-hospital, because TCP isn't used in hospital that much anymore, at least for my knowledge.
Well, the good news is, Judah, I've read some data that shows that TCP isn't super effective. So, it's probably good that it's not used in hospital that much. But Josh, I want to end it off with you, because you're working as a medic, and you were able to be the principal author of a published study. Something that we're trying to encourage people to do is to get more involved in research. And it's important to us to have someone who's working as a medic who has published a very good paper to be on the show, because we want to show, if you're an EMT and you're a medic, you can write a paper. You just have to reach out to people. So I want you, first of all, I'll ask you what we ask everybody whenever we go over papers. Give me some hope. And the second one is give us a little bit of advice on how to get papers written if I'm out there and want to actually focus on the study, and then we'll get out of here.
Yeah, I think first, as far as hope, I think that, anytime we look into an issue, whether it is disparities in analgesia or cardiac arrest survival or whatever can of worms you want to open up in your own agency, it will be ugly when you open it. And that's okay. I think that's how we get improvement. We have to see where we are to move in the positive direction. And I think there is hope for our ultrasound fans to have another indication for your butterfly to be on your ambulance or whatever, Lumify, whatever you want to use. Yep. I think that you could end up seeing that POCUS for transcutaneous pacing is like capnography for intubation. Maybe this is the only way we can confirm that pulse is there, that heart is actually beating as often as you're setting the pacer. And I think that, when we put out this paper, I got emails from paramedics, a couple in Canada, some in the US, that were like, wow, I really want to bring this home. I want to talk about this in our journal club. Please send me the PDF. I'd love to talk about it. And I think that shows how we have people that are dedicated to improving EMS care and pre-hospital care. And we do. I think everybody can think of people in their agencies, while we love to kind of rag on the dinosaurs and people that don't believe in evidence-based medicine. We also have folks that are there that are really dedicated to making the field better and to making the profession better. So I do think that there is hope, and that we can move forward as a profession on this. I think
I think that's 100% right. I think that's absolutely right. And we've had conversations previously about, finding your champion, right? If you're in a department and you want to grow it, whether it's a medical director or an advisor or even a supervisor, you want to find someone who is there to actually help and grow the practice and grow the organization. But we're interested in hearing what you guys think. Make sure you like and subscribe down below. Check out all the stuff that's down in the show notes. You can read the papers that Josh and Judah have worked on, again, linked down below. How often have you guys paced? Have you found any success, or perhaps we're failing more than we think? But for the Overrun on YouTube, I'm Ed Bowder. That's Dan Schwester. Be sure you subscribe when you hit this button. It's somewhere in this general area. At this point, you guys know I don't know where the hell the button is. But thanks so much. We'll talk to you all next week.